I have a feeling that whoever is managing Pete Hegseth's testosterone program is not giving him androgel. Like, he doesn't look like a guy that has a T level of 450. But that's what's going to happen to our troops. If the guys are genuinely hypogonadal, the most probably cost efficient thing for the DoD to do is stick to the endocrine guidelines and then use most likely topical low potency branded, androgel, et cetera, patches, the 1 or 2%. So not the best, right?
All right, welcome back to the Healthspan podcast, everyone, where we talk all things health, hormones, and staying hard to kill. Today, Dr. Andrew Winge is back with us to discuss the Secretary of Defense, Pete Hegseth's new directive requiring annual testosterone screening for military service members aged 30 and older. We're already seeing a lot of opinions about this policy, many of them heavily influenced by politics online, a lot of back and forth. So today we want to set that aside and, look at it from the patient's perspective. What are these guys going to encounter? They're going to go in, they're going to get this level back. What does that mean to them? What do they do with that information? Where do they go from there? Should they get treatment or not? We're going to kind of go through the ins and outs of it. Whether that treatment is actually going to be good and effective, and what they should expect. So, Dr. Winge is uniquely qualified for this conversation. Board certified in both family medicine and emergency medicine. Served 17 years on active duty in the United States Air Force, including multiple deployments to Iraq. Honorably discharged at rank lieutenant colonel. So he currently practices emergency medicine in Abu Dhabi. Is also the founder of Man Medicine, and that's his age management and hormone medicine practice. So Andrew, welcome back. Good to have you.
Thanks, Mike. Thanks for having me back.
Yeah, it's good to see you. It's good to see you. So a lot of back and forth on this online. It was interesting to see. But annual testosterone screening for guys in the military, 30 and over, and it sounds like we're not even guys. They just said all members, right? So
they did say all members technically.
Yeah.
I'm assuming they'll at least start with men, but
yeah, that'll be interesting. And they said it sounded like maybe optional for guys under 30 too.
That's right.
If I saw that right. So. As someone who does this kind of work, when I heard that, I'm thinking screening could be a good thing. And again, this is a unique population who might have, unique needs and maybe even lower testosterone than a lot of other populations. So to me, it seemed positive, but you'll see, there's a lot of chatter about this. So what were your kind of initial thoughts?
Yeah, I'm a little jaded from my time on active duty, but when I heard Pete Hegseth make that announcement, I just immediately thought, like, well, if there's anybody that can screw up a well-intentioned program, it's the U.S. military. Like, sure. What could possibly go wrong here? So while at a 10,000-foot view, like, I totally support screening men for low testosterone, but it needs to be done properly. I mean, this is it's a problem in the general population, and the military is generally a reflection of the general population, although slightly healthier, obviously, because you screen out a lot of the people that have serious comorbid conditions cannot get in the military. But there are certain populations in the military that have very high rates of low testosterone, especially guys with traumatic brain injuries and multiple IED blast exposures. And there's a lot of those guys. I have personal friends that have been blown up 5 or 6 times. So yeah, I don't have an objection to what they're doing. It's really, it's going to be like, how do they do this? Because there's going to be right ways to do this, and there's going to be wrong ways to do this. And I hate to say it, but the most likely route is going to be probably the wrong route. And so I think this is not going to be as effective as we would hope. But I feel still like it is a move in the right direction. At least there's official recognition from the top that this is an issue for men. So, I can't say anything negative about that. It was an issue that was completely ignored before this. So at least now it has some visibility. So I'm trying to be optimistic about it, that there will be some guys who need treatment, who are now going to get treatment that, ordinarily they wouldn't have been able to. So we'll just have to see. I think there's definitely going to be growing pains with this, like with any new program. There's going to be a lot of money wasted, but that's par for the course, in the DoD. So overall, I think it's going to be a positive in the long run, but how it's implemented and what it looks like, at least in the short run, until they get all the bugs worked out, is totally, it's up in the air. I have a feeling it's going to be a bit of a rocky road initially. So.
Yeah, I'm curious to see. And part of what you're thinking here too is, the current guidelines in general, even for the general public, are not great. So you go the traditional route. You see your primary care doctor, you see your endocrinologist, you see your urologist. You're getting these, they're going by these crappy guidelines. They don't know a lot about it. They're not super interested in it, and you get these, your low total testosterone is still fine. You're okay. No one checks a free testosterone. No one checks a sex hormone binding globulin. No one looks at your your pituitary feedback hormones, your luteinizing hormone, your follicle stimulating hormone. Are we talking about primary or secondary? Something that can be maybe corrected with lifestyle. No considerations for that. And the encounters I've had with guys who go through the VA and try to get this checked.
So bad.
I just had a conversation with a guy very recently. He's like, man, they're giving me the stink eye just even asking for the test. Like I'm asking for, or something. And then they, so then they reluctantly do the test. The test comes back, my total testosterone is 302. As close to,
you're good.
As close as you can get. He's like, no, you're all good. And he said, not only that, the doctor told him he's plenty fine. He told this particular guy said his doc told him anything over 150, you're okay. So he became confused. He's like, well, what do I do with this information? Is this guy blowing smoke?
Yeah, there are endocrinologists
really
that use that 150. I've heard, it's one of the researchers I think that was responsible for the T trials said he uses 150.
That's where he got that from.
Yeah, it probably was. Yeah, I've had multiple buddies of mine, former active duty guys, Army and Air Force, that have gone to the VA and not had great experiences. One in particular was, one of my old jiu-jitsu buddies. He was in his mid-30s, former Army infantry guy, been multiple deployments, and was very symptomatic. But he was a fit, relatively muscular guy, had a big beard. So he went in there, and he talked about, I want to be tested. I've got all these symptoms, and his internal medicine physician, she actually just flat out refused to order the test for him. She just was like no. It wasn't even a conversation. It was just no. She looked at him. She said, "You can still grow a beard. No, let's just not check this." So he was like, "Okay." So he went down the street to some free T clinic that, not a free T clinic, it was a T clinic that offered free total testosterone testing, and it came back at 120, 150. He was profoundly low, well below the guidelines. And so, he went back, saw somebody else, and they're like, oh, well, let's retest you, and blah, blah, blah. And then, long story short, he ended up just paying out of pocket to go to a private clinic, which is probably what he should have done all along. But that story's not unique. I hear stories like that all the time. And I don't mean to bash the VA too much. I've been a VA patient, and they took good care of me when it came to all of my orthopedic issues. But there's some things, just like in the regular civilian world, and definitely just like in the military, that they have big blind spots, and testosterone is definitely one of them. So what we're seeing in the VA is basically the same thing that I saw and continue to hear about in the active duty world, which is basically primary care physicians being totally out of their depth and not really being, first of all, not really interested in testosterone, suffering from all of the usual stereotypes and misconceptions regarding testosterone, and not really knowing how to even approach the question, or not even knowing when they should screen for it. And then basically just referring to endocrinology or sometimes urology because they're just this is a hot potato. I don't know what to do with it. I can't be bothered to look it up and learn about it. So they would just refer them to endocrinology. So that's kind of the state of, I got out in 2013, but I can imagine that things haven't changed that much. But the current state of, let's just say, primary care within the armed forces is probably what it was when I left, which, at least when it comes to testosterone, is just not a priority, and you got a whole group of physicians, just like in the civilian world, that are not trained. They don't understand its importance. They don't understand the pros, the cons. So there's the one of the things that's going to happen to make this program work is a massive educational campaign for physicians, because there's not enough endocrinologists to run this program, like not even close. So if we're going to be screening everybody, first of all, we probably, in my opinion, shouldn't be screening guys who are just asymptomatic. There should be a questionnaire, whether it's an Adams thing or, the aging male symptom score, some sort of validated questionnaire. And they could roll that into their PHA, which is their annual health assessment that these guys do. And then maybe they could filter out, because the guys that are asymptomatic, I mean, you could probably spare them the test. If they want to be tested, I guess I don't have an issue with them being tested, but testing a huge group, hundreds of thousands of men who are asymptomatic is probably not a smart thing. And then what do you do with all those results? So the last time I checked, there's in the entire armed services, there's something like 35 to 45 total endocrinologists everywhere. So, and there's only there's two training programs for endocrinology. I did some rotations in one of them many decades ago, but there's Bethesda Naval Hospital, which has a very good reputation. And then in San Antonio, there's like a joint services, like endocrine fellowship. So these are the only two, and they take I think they take 5 or 6 a year, through that 3-year program. So there's massive shortage of endocrinologists in the armed services in general for this program. There's enough in general for all the routine endocrine stuff that, they take care of retirees with their thyroid issues and their, diabetes and all this normal stuff
that's where they shine anyway, really. That's where
they're good at that. They're extremely capable. Like, you're not going to hear me knocking endocrinologists. They're very brilliant people. But, and then with urologists, there's somewhere between, the last numbers I looked, maybe like around 150 urologists total. So these guys, they're going to be overwhelmed with referrals, and the only way to make this work is the primary care portion. So it's going to be all of the family medicine docs, PAs, nurse practitioners, and then all of the internal medicine docs are going to need to be trained. And I can tell you, because I used to be one, they don't have any training. There's zero in medical school, or I should say close to zero for most of them. So they're going to have to be like from the ground up. And so what is that training going to look like? Well, if it's a military program, obviously it's going to have to conform to guidelines. So they're not going to make their own guidelines, I would think. They're probably just going to pick either the Endocrine Society, which is probably the most likely, because endocrinologists will probably be running this program, or they might do the American Urological Association guidelines. Not that it matters that much. They're not really that different.
Equally terrible.
Yeah. Well, the way that I look at those guidelines is like, you can stick to those guidelines, but you just be aware as a doctor, there's going to be a huge number of men that need help that you will not provide help to if you stick to those guidelines. So you'll be able to help the guys that are, under 300 or, whatever. But then there's a lot of guys above that number who need help that you won't be helping, and you'll be turning them away. So that's what's going to happen here is, it's going to be very strict. They're going to have inclusion and exclusion criteria. And they'll probably use the Endocrine Society guidelines, which again is better than nothing, but it's still, it's not what it certainly wouldn't be optimal. I have a feeling that whoever is managing Pete Hegseth's testosterone program is not giving him androgel. He doesn't look like a guy that has a T level of 450, right? So,
right.
What, but that's what's going to happen to our troops. If the guys are genuinely hypogonadal, the most probably cost efficient thing for the DoD to do is stick to the endocrine guidelines and then use most likely topical, low potency, branded, androgel, et cetera, patches, whatever, the 1 or 2%. So not the best.
I think that could
right?
be the glimmer. that could be the glimmer of hope there too, is what I was thinking. Because it's like, it's still not clear who they're gonna consult on this, what the plan's gonna be.
Yeah.
And like we talked about before, if you have a primary care doctor, or urologist, endocrinologist who actually has an interest in this personally,
Yeah.
you're more likely to find good care with that guy. Whereas,
For
if they're
sure.
following the
Yeah.
guidelines. So in this case, if the boss is super interested in it and he's passing it along, I mean, there could be a little something to it. It'd be interesting to see. But again,
Yeah.
you're right. Are they going to make their own guidelines? I mean, they could. I guess
They could.
they
They
could with some
could,
good,
but
some good guidance.
they'll probably go for the most efficient route. And again, because I almost certainly this program will be whoever is the head of the committee that runs this is going to be an endocrinologist. Whoever the medical liaison is to whoever is going to be in charge of this will most likely will be. It could be a urologist, I suppose.
I tried to elect you. I put
What's
it out
that?
there. I tried to elect you. I put it out there in one of the forums publicly, and you really shut that down real quick. You're like, oh,
Yeah, I don't think that would fly. I don't somehow I don't think that would fly. But so again, it's going to be somebody within that field, and so they'll most likely just pull their society guidelines, and those will be the guidelines that they end up using. Which again, like it's right now there's nothing. So I guess it's better than nothing. What I hope that they do, and I think logistically what they're going to have to do to make this program work, it's going to take some time to ramp up all of these primary care physicians who again don't have any testosterone training. So there are provisions in TRICARE to allow civilian referrals, out into the network. But again, the issue is like any TRT clinic that takes insurance is those are not the best clinics. The best clinics and the best providers generally don't take insurance, and I can tell you firsthand, TRICARE reimbursement is pretty bad. So the clinics that take TRICARE may not be any better than what they're getting on base.
they might be held to those crappy guidelines we talked about too now, right?
They
So
probably will. Yeah, they probably will.
take you
So
from
anyway, so it's just there's so many unanswered questions here. Um, you mentioned the workup, like that's a huge thing. Like this, you get a bunch of guys who are, let's say they're genuinely, the sub 300. They need a medical workup, and like who's going to do that medical workup? Again, the primary care doctors are not generally familiar with that workup. And then, age 30 to 40 is where a lot of these guys will fall. Many people, they end up either getting out or they retire after the age of 40. So those are prime fertility years. So now you're going to generate another big pipeline in the, assisted reproductive pipeline for these guys. And how do we keep these guys fertile? And so, this is not again, on paper, it sounds like, cool, let's do it. It's easy. But the logistics of actually making this work and then managing the downstream implications, I could just see it's going to be a red tape bureaucratic mess, just based on what I've seen in the past.
yeah.
So
I'm sure.
I guess we'll see.
I've never been inside that system, but just just seeing the workings of other government things, like, oh boy, this isn't.
Yeah, you can probably imagine. TRICARE working when I was in on active duty, I was working for the world's largest HMO. Basically, what it was. So any doctor that works for a large HMO knows exactly what that's like. And you have your formulary, and you can go off the formulary, but you have to fill out 3 different forms in triplicate and have 2 of them rejected before you get anything approved. It's a huge pain in the ass, and it's governed primarily by revenue generation, and then also cost cutting. So you're definitely constrained in terms of what you can do when you work for an HMO. It's no different. In fact, it's even worse in the military, because we have operational requirements and readiness requirements that we have to hit as well. So that's another thing. Like, how are we going to deploy these guys to Afghanistan and now to Iran? They're going to have to bring all their testosterone with them, and how do we handle that? And do we want to, what if they're on injectables? And it's not an insurmountable problem, but it's just complexity. I'm just curious how it's all going to pan out.
Yeah, no, you hit a lot of good points there. It's almost like when you see a cool concept car come out, you're like, man, this thing's going to be awesome. And then, 5, 10 years later, the thing comes out and it's just another soccer mom SUV with,
Right.
with an extra curve to it. So
Yeah.
I'm like, well, that's a
I mean,
buzzkill. So where's
people
this,
have
where's
been
this
talking
thing
about
gonna
how
go?
cool it's going to be to have flying cars for 40 years, but we basically, I don't see any flying, even here, I don't see, there's a reason we don't have flying cars yet, because, the real world application of that is a little bit more complicated than like the Jetsons.
Yeah, for sure. So some of the things that wasn't said that people kind of jump to the conclusion of is like, he's trying to create super soldiers. He wants to have everyone all hopped up
Yeah.
on testosterone. He's looking to do this kind of thing. I even saw someone comment on, one of the forums where we spend time. What does everyone think about Hegseth trying to make all these guys testosterone, 1200 plus, and if they're not, he's going to get them there. It's like that's
So they're just
not
making
good
stuff up,
anywhere. It's
obviously.
just
Just
it's just
making
made
stuff
up
up.
crap.
And
Like what are you doing here? And there's not he wasn't talking about mandatory treatment either, right?
no,
So
no.
there's that. Um, I thought it was interesting. You were saying, hey, why screen guys who are asymptomatic? I mean, that's a whole interesting topic in its
Yeah.
own. But even testosterone as a health marker is an interesting thing. So
Yeah, exactly.
a lot of
Yeah.
these guys are. I mean, you're talking about sleep deprivation,
Yep.
chronic stress,
Yep.
PTSD, TB, traumatic brain injuries,
Mhm.
whatever it might be, all this stuff. There, it's unique stressors on these guys, and that
Yep.
can result in low testosterone. And just as a health marker, that could be a nice thing to see. Doesn't mean you need to treat them for low testosterone, but you could be like, hey man, this is a red flag. We need to clean up your act
Yep.
here. What's going on with you? And maybe they
Yeah.
look like, oh man, I'm getting 4 hours of sleep, or I'm stressed out. I have some,
Mhm.
whatever it might be. And you can kind of,
Yep.
so I think even just as a data point, it's kind of an interesting thing to see. And it would be a great data set too, just to have that amount of folks. I mean, we don't have a lot of
So
great
that's
studies
a
on
great point.
testosterone, but man, that would
That
be,
that's
something.
a great point. Yeah, it's you have a captive audience, right? So
Mhm.
maybe some of that can be data mined, and we can get some additional data from it. Now, your point is like just totally well taken. Like it is a health marker. I'm approaching it from sort of a epidemiological and financial
Mhm.
approach,
Oh,
which is
sure.
how they're going to approach this. Like, does it make sense financially to screen guys who are asymptomatic? I like I like that he said if you're under the age of 30, you have the option of being tested. And I can guarantee, like most guys will be like, heck yeah, let's get me tested.
Mhm.
So, but you're right, yeah, yeah. Total testosterone is it's one of the markers, and I talked about this on other podcasts, but there's a case to be made for getting a baseline level when you're healthy and in your prime, and having that data point for later in life. I know there's a counter argument to that, obviously, but it's be nice to know, hey, what was that when I was kicking indoors as a Green Beret at 22? What was my and I felt great. What were my levels then? You know?
Mhm. Sure. Yeah,
Yeah.
no, it's an interesting point. We just had this chat with Dr. Max Draper. We were talking about treating asymptomatic low testosterone,
Yeah.
and it was
Yeah.
interesting kind of back and forth. And one of the
Yeah.
one of the points we agreed on was it really depends upon the personality and the kind of the temperament of the person who's getting the test done. What are you going to do with that information?
Yeah.
Can you take it just as a data point and move on? If I
Yeah.
test your testosterone and it's three, you feel awesome, and now I tell you your testosterone is 350. Do you not feel awesome anymore? Are you going to be
Right.
upset? Is it going to be,
Right.
or, the other thing we were talking about too was, are you really asymptomatic? Because a lot of, I'm thinking about military guys, or, they're trained to work through things. And that's
Yeah.
part of it, right? You're resilient, you're stoic, you're getting stuff done. Maybe they're slipping a little and not feeling great, and they're just gutting it out. They're just doing it. And now they
Yeah.
get this level test and they're like, man, no, I am fatigued. I am feeling
Yeah.
like garbage. Could there really
Yeah.
be something, physiological going on here? I
Yeah.
thought I was just, getting older, and here we go. The job's catching up with me.
Yeah.
So I think it's interesting in that way too, to have kind of like a
Yeah.
baseline screening, because sometimes you don't know till you know, like checking
That's true.
a hemoglobin
That's true.
A1C, or checking your blood pressure is like, whoa, I didn't know that was going on. What's happening here?
Yeah. Yeah. Well, there's some guys, that kind of to piggyback on what you just said about, testing asymptomatic guys that, yeah, they actually are symptomatic. But perhaps they've felt so bad for so long that they sort of just think that this is normal. Like I'm supposed to feel this way. So yeah, I guess I don't have any symptoms because this is I'm supposed to be feeling this way, and that's like their new normal. You know, if you've been hypogonadal for 10 years, like that's your reality. And
And it's
you
gradual
don't
too, right? You don't just
remember.
wake up one day like that.
Yeah,
Usually, it's not like an acute illness. It's a
exactly. Yeah,
slow decline, and all of a sudden, there
right.
you are.
Creeps up. It's boiling the frog, you know, and so you
Exactly.
don't know. You know, the other case though that I'm not sure if you guys mentioned this or not in the podcast, but you know, there are levels you know where testosterone like is profoundly low. You get guys like sub 120, sub 100. You know, there's a case to be made to treat those guys regardless of whether they have symptoms or not, because there's definitely health implications like osteoporosis, osteopenia, you know, bone loss, potential cardiac complications, you know, things like that. Even if they're like, no, I feel fine, you know, there's potentially some bad stuff that can happen. And oftentimes when you're that low, like if you're in double digits, to me, that's a red flag that you've got pathology somewhere. Like this isn't just you're too fat, you're too stressed, you don't sleep well, you need to go to the gym. It's like, no, like you've got a pituitary adenoma, you've got cancer, you've got some other serious autoimmune problem, whatever. So that's always been like those guys need a workup, in my opinion, and
Yeah.
and you could make a case in some cases for treating those guys. So there's
Yeah.
just like with all this stuff, like there's nuance to this. It's
Mhm.
again, people like to oversimplify stuff per our prior conversation, and this is not just like all things in medicine. Like it's not a black and white issue. There's nuance, and that's why you need expertise. You need experts, people who are well versed in this stuff. If this program is going to succeed, you know, it's going to succeed because the people running it know what they're doing. And I hate to say I don't have a ton of faith in that, at least at this stage. You know, I guess we'll see.
Yeah. And those were some points we covered too, right? Even with type 2 diabetes. I mean, I get a guy who comes to me who's type 2 diabetic and he's low. I mean, that's whether he tells me he has new symptoms or not, like this is going to help you. This is going to help you
Exactly.
become more insulin sensitive, and it's
Yep.
going to help you build some muscle and build that
Yeah.
tank to store some
Yeah.
glycogen and help you use that glucose better. And there's studies showing that we're going to improve your health. We're going to reduce your
Yeah.
diabetes. I
Yeah.
forget what the one trial, something like a 40% reduction in diabetes, some pretty
Yeah.
significant number.
Yeah.
And
The
then,
development of new diabetes over like 5 years or something.
yeah,
It's totally, and that's one of the things that tends to fall outside of the guidelines. Is that, you know, the question I always ask is, does this patient, you know, not only are they symptomatic, but do they have a medical an underlying like a compelling underlying medical reason to be on testosterone? Do they have a condition that I could improve by improving their testosterone levels? Type 2 diabetes is a perfect example of that. Maybe their level is 350 or 450. They don't feel that bad, but you know, they're on 3 oral agents and a GLP, and they're basically looking at having to be put on insulin at that point to get their sugars under control. Maybe a trial of testosterone to see if I can, you know, prevent them from having to go on, you know, basal insulin to get their A1C down. Maybe that's the better. I personally think that would be the better move for them in most cases. So there's definitely a case for that. And that's, you know, that's not in the guidelines, or
mhm.
it's sort of like they sort of graze against that, you know, or just touch on it very briefly. But to me, that's a compelling indication to start testosterone in some cases.
Oh yeah, no, that's an emergency. A type 2 diabetic who's now become insulin dependent. That's the beginning of the end for a lot of people. It's
It's a
not gonna
bad sign, right?
not gonna go in a good direction from here.
Yeah, like a lot of stuff needs to change for that
Mhm.
person, not just
Yeah.
and it's not just testosterone. A lot of stuff needs to change.
Total overhaul, total.
Yeah,
But even those trials with the testosterone and diabetes, they were bringing guys' levels up pretty high too,
they were.
right? So they got better results
Yeah,
with a super physiological range
they
than
do.
you don't get them up to 600 is maybe not the answer. We need to do a this is a therapeutic.
In some
Um,
cases,
yeah, this is a therapy, not a
yeah, it's
replacement.
pharmaceutical dosing rather than replacement dosing,
Mhm.
and it makes sense. I think we talked about this on the last podcast that you know, there's a dose dependent effect of testosterone with strength and muscle mass. You know, what is your largest glucose reservoir outside of your liver? It's muscle tissue. So more muscle tissue equals better insulin sensitivity, better glucose disposal. So it stands to reason that higher doses, especially if in a weight training and exercising patient, which I think is mandatory, there's benefits, I think, at those higher doses. So again, assuming there's no adverse effects and there's no contraindications to that, like I personally, I don't get super stressed out about taking somebody up 1100, 1200, etc. If everything else is getting better, I'm not worried about that number.
Yeah, if you feel great and all the other markers are looking good, what are we worried about? And we're looking more at the free testosterone anyway, too, right? So
True.
hopefully the military is looking at free testosterone a little bit and measuring it correctly. So
I don't know, man. I don't know. I hope so. I hope so.
I know.
But I think I think it's for cost reasons. It's going to be kind of bare bones initially. It'll probably just be a total T, and just strict adherence to most likely endocrine society guidelines. So
yeah, it's super cheap though too. I mean, it can't be it can't be expensive for the military.
Yeah, probably. I mean, they God knows they waste enough money on other stuff, right? So I'm sure they could find a way, find a way in the budget to make that happen.
If you're not afraid to spend $5,000 on a hammer, you can afford the $7 for an SHBG. I think.
Yeah, exactly. Yeah, the $10,000 toilet seats and things like that.
Right. So some of the arguments I've seen against this too is, some other military physicians saying things like, hey, the main objective for medical doctors and healthcare in the military is readiness for deployment, I think is the phrase they would call it, right? And their argument was there's no evidence that having low testosterone makes you not ready for deployment. There's no evidence that improving it would make you more more fit for deployment. And I thought that was kind of interesting. Just because there's no evidence, there's no study on it, doesn't mean it's not true. I mean, it improves recovery, it improves overall resilience. So you're less likely to get sick, you're less likely to get injured, you're more likely to be more clear in the head. I mean, that sounds ready for deployment to me. I don't know why they think that's not a thing.
Well, whenever they say there's no evidence for, whatever, you have to take that statement literally, because what you're implying, what a lot of people hear when they hear that phrase is that this has been studied and it shows there's no evidence.
Right.
But what they're really saying is there's no evidence. There's no evidence because it hasn't been looked at. Mm-hmm. And it entirely makes sense that if you're a lethargic and hypogonadal, symptomatically hypogonadal, that guess what? Like you're probably not going to be performing at your peak when you are in a combat environment. Do you want your F-35 pilots to be hypogonadal? Like I don't. Do you want the guys flying the drones to be exhausted and low T? Do you want your special forces guys who are, going in behind the lines in Iran and, running all over the countryside there? You want those guys to have low testosterone? Like, no. So it's obvious to me that having a healthy, robust testosterone level is going to help with all the stuff that happens in the military. Even the logistics guys who are back at the FOB, and they never leave the base, like they need to be sharp mentally. When you deploy, you work very long hours sometimes. When the ops tempo is very high, you might not sleep for 36 hours, 48 hours, depending on what missions are being run. In my last deployment, I was the only board certified ER physician for it's about a 150 to 200 mile radius up in northern Iraq. And I carried a pager. I was on call 24 hours a day, 7 days a week for 6 months. So the ops tempo was sometimes super slow and sleepy, and it was great. And then other days it was completely insane, and it stayed insane for days and days and days at a time. So, you have to be resilient, and you have to be physically fit and mentally fit, and you have to bring your A game. For me as a physician, when we'd have a mass casualty event, and having, multiple wounded soldiers and civilians coming in, you have to bring your A game to that. And, it's hard to bring your A game when you're hypogonadal. So it makes sense to me that, this is war is real. War is the real thing. Like you need to show up, and you need to show up in your best possible condition. And it's kind of hard to do that with low testosterone, especially if you're one of these guys that's, at the tip of the spear. Like if you're putting rounds down range and dropping bombs on targets, you don't want your guys hypogonadal. So, and that's where Hegseth, he gets that part of it correct.
Yeah, and I think it's interesting too, though. So and you hear that too, and a lot of people even dial it back when they hear that and say, "Oh, yeah, if we're talking about these guys, it's a different story. Some elite group, this, that, the other." That's a pretty unique group of individuals too. I mean,
Oh my God,
they're just it's a whole different. I mean, just the mental resilience and the physical resilience and the train, just all of it, right?
yeah,
But it doesn't mean that the stress that other people on different levels of it. I mean, to them, those stressors are maybe
yeah,
equally high for what they're doing for their job. I mean, they're at the level of what they can do and what they can handle. So
yeah.
I think you have to kind of extend the same kind of courtesy if you're asking someone to go to to war and risk their life and
Mm-hmm.
all these things, all these important things. I think let them be optimized. Let them feel good and be at their
Absolutely,
best. Give them the best chance of coming home. How about that, right? They come home
exactly.
safe.
Yeah,
Their buddies come home, come home safe. I'd imagine
yeah.
I'd rather have, if I'm out there, I want the guys with me to be as dialed in as they could be. Right? Let's
Absolutely,
all
you do.
get the hell out of
Absolutely,
here.
yeah. Because in those environments, you're relying on your buddies. You know, it's you all need to show up, and the you don't want to be the weakest link in that group for sure. You know,
Yeah. And I think, the flip side of that too is a lot of, the public hears that kind of thing too. And they're picturing guys just all hopped up on, modafinil and super high testosterone. Maybe they're taking trenbolone and they're just, they're popping something
yeah,
right before they go into battle and they're just out of
right,
their mind, high testosterone, crazy people going
of
after it.
course.
And that's not the kind of person you want out there either, right? You want the cool, calm,
No,
collected guy who's at the top of his game,
no,
right? It's the same with law enforcement officers. People worry
yeah,
about. I've had some people tell me, "Hey, I don't think I want a cop who has high testosterone." I think you do. I
you
think that's
do.
the
You
guy you want
totally
to
do.
show up.
Yeah,
You want the cool, calm, collected guy who knows how to handle a situation, who knows violence if he needs to use it, but he also knows how to
yeah,
de-escalate because he's in a good headspace, and
yeah.
that's what you want. And that's not a low testosterone guy. That's a high
No,
testosterone guy.
no. Well, the people that say what the stuff that you just mentioned. I mean, there's obviously they're declaring themselves as ignorant, and they're just parroting some of the misconceptions that the general
Mhm.
public has had for 50, 60 years about testosterone and steroids and all this sort of stuff. And so I hope that the people that are involved in this program on the political side are not people like that, but there's going to be some of them that they need to be educated, because you and I know that stuff is nonsense. And those are just stereotypes, and
Yeah.
bad
One of
stuff.
the one of the I forget what show, and it doesn't matter which show it was, but in one of those talk news shows, one of the hosts on there was saying that all the women on the army bases and all the surrounding areas where guys are stationed in foreign places need to be worried because there's going to be higher rates of sexual assault
Yeah, come
and
on.
aggression, and
Right.
it's like it's not the way this works either, man.
No.
It's just
I mean,
not. It's silly talk.
it's stupid, right? That's nonsense.
It's out of control. So, and I've heard thrown around here too. They say things like operator syndrome, kind of like what you were talking about with some of these guys, right? So they have this chronic state of fatigue and physical
Right.
and mental
Yeah.
injury, and it can turn into more of a chronic thing. So I think
Yeah.
that does make these military guys kind of a unique thing, because one of the pushbacks you hear from the public too is like, oh, we're testing all these young guys, but I think the job is probably aging these guys a little prematurely.
There's no doubt. Yeah, there's no doubt about it. Again, especially as you go more into the elite, top tier units, becomes more of an issue. These guys know how to push themselves, and their limits are far beyond a normal person's limits, and they will push themselves to get the mission done, and they will definitely sacrifice their health to get it done because that's what they're trained to do. So, yeah, they do. I think they do suffer more. They have a lot of circadian disruption. These are guys that a lot of them, almost all of them that I know, have had traumatic brain injuries to some extent or another. Either minor or sometimes major. Blast injury is part of that, and that's one of those groups that unfortunately they do have very high rates of not just low testosterone, but like just pituitary dysfunction in general. Sure. So there's high rates of growth hormone deficiency, which, if you can imagine how poor that we have been at recognizing low testosterone, how bad do you think they are at recognizing growth hormone deficiency, especially in 30-year-old operators? So terrible, right? So those guys at the very tip of the spear, they are deploying constantly. They're constantly under physical and mental stress, and it takes a toll on these guys. Some of my best friends are Green Berets, and they have the highest suicide rate. The highest suicide rate in the military, and there's a reason for that. These guys are exceptional. They're exceptional athletes. They're highly intelligent. Average IQs are like 120 to 130. They're very hard charging and driven guys, but they also internalize a lot of things. And, it was always kind of a running joke when like I would sometimes do retirement physicals and things like that. And, these guys would come in after like a 20-year career in special operations, and they'd have like 3 pieces of paper in their medical chart. Meanwhile, like I know you've been blown up 7 or 8 times, you've deployed half a dozen times, and you're going to tell me that all you have in your chart is like you had a sprained ankle coming out of basic. So they don't go to the doctor, they don't want to get on the radar. And in the Air Force too, the other part of that is the pilots. So the pilots don't want to come in either because they don't want to be deniffed, which is, not fit to fly. And for the pilots, like almost anything can make you deniff. Almost anything. Like you get on an antihistamine, for a sinus infection, you get on, certain antibiotics, you cannot fly, you can't go on the mission. So again, you're an F-15 or F-35 pilot. I'm going to stay away from the flight surgeon's office, right?
Yeah,
so
makes sense.
In some ways, again, having this program they don't have a choice. They're going to have to come in and get some sort of screening.
Yeah. You mentioned the mental health aspect too. So I mean that's a big thing with hormones.
It's unrecognized, totally
You
unrecognized.
see a lot of that. I mean, so when I did, in my schooling, I did some rotations in the ER in the VA, and I bet 80% or more of these guys were on some sort of antidepressant and something for sleep, and then up from there. But at a minimum, any chart, like everyone's taking trazodone and an SSRI. Yes. And then plus, whatever it might be, depending upon their thing. I was like, holy cow, this is a lot more than the general population for sure. Because I was doing those rounds
for sure.
Like, man.
For sure. Yeah. Yeah, absolutely. And they're guys, they can get hooked on stuff like that. When you go out on a 48-hour mission and then you come back and you're just like hopped up on caffeine and modafinil because you've had to take that because you're out getting bad guys and not slept for 48 hours. These guys, they take downers, Ambien, Restoril, whatever, so there's a cycle of like stimulants and sedatives, depending on how high the ops tempo is, that can really mess you up.
Oh yeah.
Really mess you up. The other part of this too, I guess we haven't touched on this, many of these guys who get seriously wounded end up on chronic opiates or even a Suboxone. Now, many times if you're that bad off, they will medically board you out of the military, but then they're still within the TRICARE system, most of them, certainly within the VA system. And, if there's one thing that will tank your testosterone, your natural testosterone, it's opiates. So that's a population that probably does deserve screening, is, not just the traumatic brain injury guys, but the guys that have, serious combat related wounds and they're opiate dependent,
Oh, it's
those
huge.
guys have they have a lot of high rate of low testosterone. It's very common.
Mhm.
So
No, that's hugely important for sure.
yeah,
Yeah. Yeah. And on the mental, the mental health side of it, we see a lot of guys. I'm sure you've seen a lot too. They come in, they're on multiple, and this isn't the case for everyone. It's not saying no psychiatric medications are ever needed. They're great for, for what they are and when they're needed. But there's plenty of times where guys come in, they're on these meds, their testosterone's super low. We get them back in range for a while. They don't need this junk anymore. They're off it.
yeah,
They're like, holy cow, I was taking this crap for 10 years.
right.
And they just, so it could be, an interesting finding too. Guys might find that they come in, they get screened like, man, I've been taking these other meds. Maybe there's something to this. So hopefully the, whoever's doing those screenings puts that together too. Again,
Yeah,
I'm not cross,
yeah.
hold them.
I've seen the same thing. I mean, I think anybody that treats men with testosterone, if you've got enough volume through your clinic, you've seen this exact thing happen, where a guy will come in on an SSRI or some other antidepressant and be sort of, have a lackluster or no response to it, and nobody's ever bothered to check a testosterone. Like,
Mhm.
I think in most cases that's part of the workup for somebody who has depression in a man, is at least check their testosterone. It's not that difficult, to do that. So I occasionally get psychiatry residents that rotate with me through the emergency department, and they don't leave that rotation without me at least mentioning that once.
No, it's
Hey,
excellent.
just, before you put somebody on antipsychotics and SSRIs, and just like do your due diligence, right? Just at least screen for it.
Yeah.
And yeah, I mean, we've all seen, if they don't come off of their antidepressants, I've seen many guys been able to drop the dose, or like they're on multiple drugs, maybe just go down to one, which
Sure.
they've been able to de-escalate, which is fantastic.
Yeah,
So
without a doubt. Yeah, any mental health issue. I mean, check it, do a thorough thyroid screening, go
yeah,
beyond just the TSH to see what's happening there, check a
yeah,
testosterone level.
yeah,
You tune up a lot of stuff with that. And what's it going to hurt by looking? If you're looking, it's normal. It's like, well, we looked.
yeah.
Not
But
a,
unfortunately, that doesn't happen. Even in the primary care world, I was guilty of that when I was a junior family physician. I had prescribed Prozac and Zoloft, and thinking back, I'm like, God, I don't know that I did any labs on some of these people. I
mm,
just, you sound sad. Here's here's some pills. That was probably the wrong thing to do. But you live and you learn through your career.
for sure, for sure. I saw an interesting argument too. Someone was saying, say we had these guys, say they come back, they have low testosterone, we get them treated. Now they're going to be deployed. They said, well, how do we follow up while they're deployed? They're going to be gone for a while. They're going to need
Yeah,
some screening. What do we do?
yeah,
What if they're, one of the points that kept coming up was hemoglobin and hematocrit. What if their hematocrit's too high? How are we going to track that? And what are we going to do with
right.
them? And my answer to that was, I mean, no one asked me, but it probably doesn't matter, and I probably don't care, and it might even be beneficial for them
Well, right. I
at a
mean, we
point.
we know the deal with hematocrit, but I totally could see, the rest of the medical world does not share that opinion. So yeah, there's going to be a lot of doctors with their panties in a wad, so to speak, about this, especially as the guys get closer to deployment. These guys are out training; they're going to come in dehydrated, and their hematocrit's going to be 55%. And now it's like, what do we do? Do we scrub the deployment? Are they fit to fly? We're going to send them to the desert where they're going to, we're going to sweat more. Yeah, these are all like these are all these like downrange complications of this program that I don't know if they've been thought out that well.
Mm.
So it's going to be, that's why I said it's going to be kind of a shit show the first couple of years, until they get all this stuff sorted out. That's my prediction. I could be wrong, but we'll see.
And so hopefully they don't phlebotomy. I'm picturing that going the other way though now, right? So like, well, we want to make you fit to go, so we're gonna phlebotomize you, keep an eye on you. I hope they're checking a ferritin level. I really do.
I
I
would
hope
hope
that's part
so.
of it
I would
too.
hope
A lot
so.
of so many people just don't check that until people are grossly symptomatic, because now you're going to put them in a really bad spot. Now we made you anemic, and we're asking you to go out and
Right.
and perform and
Yeah.
come back.
I would hope that they will, they'll have some hematologists that weigh in on the board and what the ultimate protocol would look like. And, I'd hope they would be the voice of reason with that and hopefully not let that happen. But again, if they stick to androgel, the number of guys that get serious, erythrocytosis with androgel is pretty low because you never get your levels high enough to even worry about that. So maybe it won't be as big of an issue, but there will be guys, there's hyper responders out there, and it's they're going to have to deal with that. They're going to have to make a policy. So
yeah. And you're to like bringing meds with you too. What would a policy be about having needles when you're traveling? And are you I don't know what living conditions are like for a lot of these guys too. Is it sanitary enough? Do you have a couple times a week where you can actually fit in a shot? I don't know. It sounds like with that schedule, variable. Might be a little, maybe sometimes yes, sometimes no.
Yeah.
But not that a few missed treatments these are long acting medications. It would probably be fine. It really wouldn't be a big deal. Maybe with the androgel, they can just have androgel tubs, and the guys, as part of their day, they just go sitting there for 15 minutes, and everyone's getting an adequate dose now, so they can get because you need a lot of that stuff to make a.
What they'll probably do. This is just something that came into my head is these guys that a lot of military deployments, like our deployments in the Air Force, were 6 months, so it's kind of. That's a number that's fairly common. Is they, will probably put these guys on things something like Nebido. They'll give them their big load dose before they ship out, and then maybe once while they're over there, they'll be assigned to come into the clinic, or come into the medical aid tent, and the corpsman will give them their second Nebido shot, and then off they go, and then they'll be, probably just running out and getting low by the time they're ready for them to come back, and then they'll start back on whatever they were taking. So I could see there's probably some different ways that they're going to approach this. With deployments are always a challenge because you're right, like this often is not a very sanitary environment. If you're in the Navy and you're on a ship, it's fine. If you're on some of these big established bases in the Middle East that we have, some of the accommodations are pretty decent, But if you're in an undeveloped fob, or some temporary base, it's pretty dirty. Pretty dirty.
I've said a couple of times on some videos, and half kidding, half not. People ask about pellets sometimes, and I say, yeah, terrible option. I don't love it. But then I always put in there, I say, you know what? I think, the only reason I would do something like that is if I was being deployed to war, or if I had to go to prison.
Yeah.
Right. If I had or some other environment where any other administration method wasn't practical. And this, I mean, it's better than nothing, right?
I guess it's better
to be out there for some unknown period of time. There could be something to it.
Yeah.
It's not ideal.
I'm sure all of those possibilities will be on the table, and I'll be curious to see what they end up doing.
Yeah, it'll be interesting for sure. It'd be interesting if that came back up with the pellet thing, because not an ideal treatment, but nothing about what you're doing in that environment is necessarily ideal.
No, nothing's ideal. I think I guess if I had to choose between Nebido and pellets in a deployed environment, I'd probably go with the Nebido. Just because the last thing you want is to be out in the field and have freshly inserted pellets, extravasate and have that wound pop open, and
now you have an open wound,
get a cellulitis or infection, from it.
Sure.
Blah blah blah. So anyway, it's going to be interesting. We'll see.
Yeah, I don't know what kind of options. So again, with this video, I'm hoping that. Maybe some guys who, whatever the time frame is for this thing, it started, they get screened, they get some number back, and, maybe they see this, and just be aware you're probably, and it could be wrong, you're probably going to get some pretty bad advice and offer some pretty bad treatment. And, maybe, seek the advice of an expert, even if it means just talking to someone to run the plan by them, to spend a couple bucks and talk to someone who knows what they're doing. So you're getting some good advice one way or the other, and then make an informed decision. Maybe an informed consumer.
Yeah, that would be my recommendation to these guys in the military that, is if you can afford it, which, if you're an NCO and above, you should make enough money that you can afford it. I personally would recommend just finding a competent civilian provider outside of the TRICARE insurance network and just get your care done privately. And then, when you deploy, okay, fine. Like you just do the best you can, whether you have to rely on the military's contingencies for you, or you can work something out with your private doc. But that's what I would recommend. Now the problem, they got the younger guys who qualify, the junior enlisted people, they probably are not going to be able to afford to do that. But if you're an E6 and above, like you've got enough disposable cash, so you can afford maybe not the world's best TRT clinic, but you can certainly afford, something that's maybe a little bit more customized. So that's if I was in those shoes, if I was still back on active duty, that's what I would do. Absolutely.
Yeah,
I would go civilian side 100%.
I think that's good advice for sure. For sure.
Yeah.
Yeah. So hopefully some of these guys see this. So as we were talking here too, we were talking about hemoglobin and hematocrit. It's always a big thing too. Like, oh, what's a number? Where do you phlebotomize? Where's the line? Because even guys, like we talk about, we don't do it routinely. We don't recommend it. It's just going to bounce back.
Yeah.
If you do it frequent, it's not a sustainable plan. Your iron's going to fall in the background. Yeah. Just not a great plan. To you, is there a hard number where you actually do feel worried? I mean, this is a
I get asked this a lot.
It's a tough question, but what do you think?
So there is not a hard number for me. My policy with phlebotomy is this: if your hematocrit is elevated to the point where you're symptomatic and it's not a hydration issue, I don't have a problem with you. Like by all means, like go donate, get that hematocrit down so you feel better. But then now we need to change. It's like something needs to change.
Mm-hmm.
We need to figure out what's going on. We need to make sure you haven't developed sleep apnea. There's not some other reason why your hematocrit is going up. And then we need to adjust your protocol so that this doesn't happen anymore. And so that's how I approach hematocrit. But, you and I both know the research out there when it comes to secondary erythrocytosis, and whether it's from testosterone, from altitude, whether it's from people with unoperated like congenital cyanotic heart disease, many of whom walk around with hematocrits above 60%, don't seem to have increased risks of thrombosis and all the complications that we worry about. So yeah, I don't freak out when it goes above 54%. The problem is that number now just is in the guidelines, and so it's sort of, even though it's not meant to be, it's been interpreted as that's the standard of care. So the sad reality is, like, at least in the United States, if you and I, let's say, if we have a patient who is unfortunately has a stroke, it's a hypertensive, overweight, diabetic guy with sleep apnea who also happens to be on testosterone, has a stroke. And, when he gets admitted to the stroke center, his hematocrit is 54.5%. We're going to get blamed for that stroke. It's not the hypertension. It's not the diabetes. It's not the obesity and the sleep apnea. It's going to be, that's what they're going to dial in on. And so you're held to that legal standard, and there's liability if there's a complication, unfortunately, even though, you and I both know, and most people that are in this field who actually study this stuff know that, it's probably not the cause of this guy's stroke. It's the other things. It's the other things. So it's a tricky situation because we're held now to this standard many times, and we're open to liability if something happens and that hematocrit is 54, above 54%, which again it's a completely arbitrary number. It's everybody, you can fact check this if you want to. It's an arbitrary number that the Endocrine Society and the AUA experts decided on. It's not an evidence-based number. It's just, we have to pick a number. Let's pick this number. So it's, I guess, roundabout way of answering your question.
No, it was pretty. That was pretty on point there. I like that. I like it. It's usually you mentioned those heart failure patients, with the cyanotic
Yeah.
heart failure.
Yeah.
I keep going back in and looking just to. I always do
Yeah.
a literature search just to see, am I actually missing something? Is there really something to this? It just blows my mind that it's so just arbitrary and made up.
Yeah.
And that's the only thing I caught about that was one study where they were saying in that population, those heart failure patients, they were saying, hey, we think above 65% hematocrit, we should really start paying attention and be a little
Yeah.
worried.
And
There was
but
blurb about
notice how
that.
they couch that though. We think
Right. No, and it
you
wasn't,
probably should.
it
It's not
wasn't
like
we've seen
this
it
randomized
demonstrated.
study shows,
Mhm.
it's we think. So it's expert opinion, right? Which again is the lowest form of evidence. I mean, it sounds reasonable, right? Like I'm not going to argue with 65% is pretty high, but
Yeah, it sounds like something bad's going on. Maybe
if
we
you
should
had to say,
check.
or if you had to say, okay, prove it, prove to me that bad things happen at 66 that don't happen at 64. It's a little, that might be a challenge for them.
Mhm.
Again, I don't think it's unreasonable. I'm not going to let my TRT patients run around at 60 above 60%. Like we're going to fix that because I don't like that number. I don't. If something bad happens to you, I'm going to get blamed for that number. Like we're bringing that number down, and usually that's not. It's not too difficult to do that. So
Yeah, it's usually something going on. Some other,
there's something
have some
going on.
sleep
Yeah.
apnea.
Yeah.
You're not your fitness is way out of whack. Your protocol is just
Mm-hmm.
not good, and you fix all those things, and you get back to a more
Yeah.
reasonable number. And it doesn't have to be under 54%. I'm seeing
I
a lot
had
of
it was a couple years ago. I got norovirus, and so I got I was losing
mm,
fluids from both ends, and
nice.
I got pretty dehydrated, and I was like, I want to check my hematocrit and see what it is. It was like 59%,
Mm.
you know, and I felt terrible, but I felt terrible because I had norovirus and I needed like 4 or 5 liters of fluid to get me right again.
Yeah,
So
and the last thing you needed was phlebotomy.
right,
That would
yeah,
have
the
would have
phlebotomy
not
would not have
helped.
helped me, right? It would not have helped me at all.
Done the
I
job.
needed some fluids. So
Yeah.
yeah, that was fun.
Oof, good stuff. Good stuff. I'm seeing a lot of primary care clinics and even some TRT clinics. They have their own number now too. Like 54 is still too high. They don't even want to approach that, so they see 50 even. I've seen
Yeah,
guys.
I worked for a
There's
clinic
like,
years ago that the owner would lose his fucking mind above 50, and it's just like, dude,
what are
that
we
first of all,
doing?
that's a normal hematocrit,
Yeah.
um, and if you think there's no evidence for above 54, there's like just no evidence at all for 50, but yeah, it's live. It's one. It's like they don't. They're not that knowledgeable about the research, and then second of all is fear of liability, which that I understand. I understand. It's we live in a very litigious society,
Mhm.
and you have to if you're running a business, you sometimes have to have protocols and have systems in place that maybe are not the most evidence based thing, but they're designed to protect you. So
Sure.
I get it.
And that's the exact. I mean, I'm honest with my patients too, and I tell them that exact kind of thing.
Yeah.
Like here's what the guidelines say. Here's what
Mm-hmm.
here's my take on the evidence.
Yeah.
Here's
I do the
the
same thing.
reality is, if
Yeah.
something bad happened to you, even if you tell me you're not going to sue me, your
Right.
wife might not be happy.
Yeah. Yeah. It
She's
just
like, hey, I told them not to do that TRT
mm,
thing, and
it's
now here we go. So yeah, it's a tough one. But on the other part of that question too is, say you're working in the ER and someone comes in for, some incidental thing and you're just checking some blood, whatever, it's a minor trauma or something. And you got a CBC as part of the workup and they're elevated, they're 58%, something
yeah.
like that. I mean, you're not getting super excited there and saying, whoa, 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 what are
No,
we doing?
no, I see that not infrequently actually here because of you see it with COPDers. There's a lot of guys on underground gear here, so some big boys that come in with unrelated things, and they're getting labs, and
Yeah,
it's obvious from across the room why their hematocrit is high. When you look at some of these guys, but yeah, it's many of these guys, like the COPDers, I would harm them. I could kill them if I phlebotomize them.
mhm.
There's a reason why they have a hematocrit of 56%. It's because their body needs it. So it's the
Right.
same with these, like the cyanotic heart disease people. Their oxygen saturations are they live in the low 80s sometimes. They just live there, and so that's the way that their body adapts. If you phlebotomize those people, you cause harm. You cause harm to them. That's
Yeah, it's
not
an
the same as
adaptation.
TRT, obviously, but you do run the potential of causing harm in a different way with a man on TRT in terms of the ferritin issue.
Yeah. So for that, I mean, those particular patients in the ER who come in, like even this guy on the gear, or the person who's not a COPD or not a heart failure patient, you see this number. I would bet it's just the you mentioned it to them. There's no further workup, even, right? I mean, you're not getting an EPO and a Jack two
Well, it kind of
conventional
depends.
lab.
If they swear up and down, if they're not on, if I don't have an obvious reason for it, I mean, I absolutely, because many times they're not aware of it.
Mm.
If I talk to my patients, if I get any abnormal lab result, I've let them know verbally, and I document in the chart that I let them know, because you never know what that's going to be down the road.
Oh, sure.
So sometimes you find stuff that you're looking for something else, and you get this, oh, by the way, finding, and so to cover me and to keep the patient informed, I always let them know about abnormal lab results. But yeah, if they don't have a good reason to have their hematocrit, I ask them all the usual questions. I sometimes I'm like, did I just discover somebody with a JAK2 mutation who's going to be developing polycythemia vera? So yeah, I actually will, out of the ER, because I don't have the ability to follow those people up personally. I refer them.
Sure.
I refer them either back to their primary for retesting, or if possible, or if they wish, I'll send them directly to hematology. If they have an obvious reason for it, I mean, I still have that conversation with them, but I tell them I think it's probably because of this. You know,
Right. 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 But the overriding point being too, it's not an emergency. In
it's
the
definitely
emergency
not
room,
an
you're taking
emergency.
care of the emergency.
Not
You're
an
addressing the
emergency.
other things, and you're all
No.
right. Talk to your people about this. You're
Yeah.
aware. We're going to follow up on this
Yeah.
and
I
see
do
what's
it as
going
an
on.
FYI. Hey, listen, everything's looking good with your chest x-ray, blah, blah, blah. You've got a small pneumonia. You'll be okay. Hey, by the way, this is what I saw in your blood tests. You need to know. And so, yeah, please follow this up and just make sure there's nothing else going on. Just simple.
Yeah,
Just,
that's a good. That takes us kind of full circle on. Sometimes screening for stuff is a good thing. You find things
well, sometimes you do. Yeah. Yeah. And in, we get accused of over ordering tests in the ER, and sometimes we kind of do.
easy.
But a lot of us that
Really
have been
is.
doing this for a very long time continue to order a lot of tests because we find stuff. It's just like we're not just doing this because we're what we like to waste money. Like we find stuff that is sometimes unexpected
Mhm.
and sometimes really serious. So
Oh
yeah,
yeah.
there's pros and cons to screening for sure.
Oh yeah, yeah. In the ER, there's all kinds of guidelines and rules for getting imaging or labs or whatever it might
Mm-hmm.
be. But after a while, your gut tells you, like, hey, in these patients, I'm doing this extra thing. I've seen it enough times pay off where
Yeah,
we catch something or miss something, we send in the wrong person home or whatever it might be.
yeah,
So yeah, I think that's
yeah.
that's
There's
usually.
some things where if you want to be a purist, like it's a young healthy person, you don't need any labs.
Oh
You don't
sure.
get labs. There's no actual reason to get labs on him for something. But I also know that there's no way I'm going to get this guy admitted to the internal medicine team without some labs.
Mm.
So I'm like, let me just shoot some basic labs so I can get this guy in the door, because I know the doc that I call to admit this patient is not going to be comfortable admitting them with no labs,
Right,
even
right.
though they're like a healthy 20-year-old. You
Mhm.
know, so
Yeah, for sure, for sure. So if I know you already declined the job, but if Pete Hegseth or the Pentagon called you and offered you the world, would there be any basic recommendations you would make to them?
oh man, yeah, I think I would say, listen, let's at least screen the if we're going to screen everybody, let's screen them with a questionnaire first with like a good history, and then let's take those guys that we're suspicious, let's test them, and then we need to stand up a very comprehensive educational program for the docs that are going to be seeing these guys, because that's the major deficiency right now, in my opinion. In addition to all the logistical questions, it's how do we get these internal medicine and family physicians and PAs and NPs, how do we get them up to speed on this? So like we need to make a course. We need to hire somebody who can come in and teach these guys, and then we need to set up a protocol that lets this thing run smoothly. And we need to have a pipeline. We need to, the military service, the medical service is chronically understaffed in all areas. This is going to put a big strain on a system that's already understaffed, and so I'll be like, Pete, give me some money, because I need to recruit more physicians. I need more nurses. I need more technicians. I need more phlebotomists. If we're going to make this work, we can't have 3 to 6 month waits to get these guys in. They need to get in and out. They need to either qualify for treatment or not. And you need manpower for that, and you need money. So I'm going to just decline that job. I would be happy to come in and do some training and educate them. I could do the educational part.
No, a consultant role for sure. You don't need
I do the
another job.
Yeah.
You don't need another full-time job. Maybe a little quick in and out kind of thing.
Yeah.
This is one last, one point too. I meant to bring up earlier when we were talking about, guys finding an expert and maybe doing it on their own. Yeah. What's going to happen when those guys do that? And now they're getting this mandatory testing, and they come back in and their total testosterone is 1,300.
Well, right. So we know what's going to happen, right? That's pretty predictable.
What are you doing?
That's pretty predictable.
Right?
I mean, if the docs that are doing this program, if they get proper training, then it won't be an issue. So it all depends on the level of training. But I guarantee they're going to see that red number, and there's going to be alarm bells. The family doctor is going to be like, oh, we need to get you down to whatever. We need to get you down according to the guidelines between 450 and 600. And, they're going to be, I think that's another level of headache, that these guys are going to have. So what'll happen, I think, is these guys in the military, they're not stupid. They're going to game the system if they're getting TRT from an outside clinic, they'll know when they have to come in to get their military blood drawn, and they'll just time their dose. So they hit the nadir and they come in at 450 on their total. And then they'll go right back on their program to get them back up to 1,200 or 1,300. That's what's probably going to happen.
Yeah, you hate to coach people on how to game the system, but if it's improving their health, or even some guys on 20% compounded cream, right? Not the androgel.
It'll be easier for them.
Short acting can get.
That's what they'll do.
Whatever you want.
These guys are not. They're not dumb. They're all going to talk, and they'll figure it out.
Figure it out. Yeah. Interesting. Yeah. And I think this was a great talk. Hopefully, guys who are, out there getting their levels checked and have questions, find this. And, if they do see it, or you have a family member, forward it to them and, share it with them, and, hit the like button, hit the subscribe button, share it so we can get the message out there. And if there's questions, put them in the comments here.
Yeah, absolutely.
And answer them too, and see what,
and I'd like to plug, Stephen Devos's channel and the forum to the TRT and hormone optimization forum on Facebook, and then the YouTube channel is, if you're a active duty guy and testosterone's on the radar for you, I think that's one-stop shopping. Like everything you need to know about the safe, proper, effective, and reasonable way to do TRT. Everything you need to know is on that channel, and you should probably tell your doctor to watch it too, because they can definitely learn some things as well. So.
Oh yeah, no, I couldn't agree more. Agree more. Yeah, hop on there. You're going to see a good group of people.
Yeah, and it's the single best source, like the single, I think, one-stop shop for good, like evidence-based testosterone information. Just you're not going to go wrong there. All the docs that are on there, you and I know them. They're all excellent.
Yeah, it's great, and a great resource too if you're looking for someone, right? I mean,
for sure. Yeah, exactly. You don't even need to go beyond that group. It doesn't matter who you pick in there. In general, they're all going to be good.
You're going to get a solid recommendation. No, I think that's an excellent point. Yeah, it's a great spot to be. And if people want to, find you online, see your stuff, contact you about your clinic, even what's the best way to do it? And
the easiest way is just the website. Like it's manmedicine.com. You can contact me through there. I'm available for consultations. If you've got an issue that you need some help with, I'm happy to do that. I do consultations with men all over the world. I've got guys in every corner of the world on every continent besides Antarctica. And I really enjoy doing those. So if I can help you out, please, reach out.
Nice. Yeah, I'll put some links below too, so you guys can make it easy to click on. Awesome, Andrew. Thanks for coming on again.
Hey, my pleasure, man.
I hope
Anytime.
We can do it again soon.
Yeah, hopefully we'll get to do it again.
Awesome. All right, take care.
All right.